Welcome, everybody. Thank you very much for joining us today. My name is Sarah Canavati, and I'm a Senior Malaria Advisor at Save the Children US. I will be the moderator for this panel session titled Use of Digital Tools and Data on Different Maturity Levels. Just a couple of housekeeping announcements. Please use the question and answer function or chat to post your questions. The session will be recorded, and please choose your language channel, English or French. So we have a number of different speakers today that are joining us. Our first speaker for today is Elijah Egwu. Elijah Egwu is a Senior Program Manager for ICT4D for Health Applications at Catholic Relief Services in Benin. We have Christopher Lorenko. Christopher is the Deputy Director for Malaria at Population Services International here in Washington, D.C. Moise Hug Rene Abomao. He is the Head of Monitoring and Evaluation Unit at the National Malaria Control Program in Cameroon. And Bram Piot, he is Senior Surveillance and Monitoring Advisor in Asia at Population Services International based in Vientiane in Laos. Thank you very much, everyone, for joining us today. Our first speaker, as I just mentioned, is Elijah Egwu, and he'll be presenting on digitizing health projects in Benin with integrated end-to-end multiple disease campaign tools. Elijah, thank you very much for joining us today.
Thank you so much, Sarah. Good afternoon, everyone. I will be presenting on the said subject from Benin. I would actually be speaking on the digital tools and the data used across health campaigns in Benin. For those of us who may be new to this topic, typically we have preventive health campaigns that are being done in different countries where community health workers are trained with tools, and then they utilize these tools and move from house to house to distribute preventive health, medications or health commodities to this household. In some cases, they use the tool to receive like data of the people living in the households and also the commodities that they have distributed. Now, up until the early 20s, typically these health campaigns have been done traditionally using paper-based tools. The implication of this is that the community health workers will take like a register and move from house to house to receive this information. However, over a few years, things have now changed, and the tools that are being used in the household by the community health workers have now been changed into digital tools that are used on Android phones or tablets, as the case may be. In Benin, since 2019, we have actually been digitizing a couple of health campaigns through funding from the Bill and Melinda Gates Foundation, and we had digitized the IT distribution campaign, SMC, and also the psoriasis, river blindness prevention campaign. Now, across these campaigns, the community health workers are trained on how to receive the relevant information from the household on their phones, and then this is reported on a dashboard. Now, the data that is usually generated in these health campaigns up until 2019 in Benin would be received on paper, and apparently the Ministry of Health would, in most cases, have to wait till the end of the day to see the results of the number of households that have been served, and the people that have been treated, and the location that have been covered. And apparently, at the national level, they would have to wait till the end of the campaign, where all the paper results are collated, to receive a report on the coverage rate of the campaigns in different locations. Now, in 2019, where we now have to change these paper tools to the digital tools, yes, the forms were the same, and the approach for receiving the data in the households were also the same. However, it will be noted that the data you receive through the digital tools actually would be accompanied with more data than the data you receive on the paper-based tool. How do I mean? If a community health worker is in a household and is receiving the number of people who are living in the household, and he put that number on his register, their names, their age, and their sex. On the digital tool, yes, you receive the same information, but the phone will receive additional data as trace data to show the time of the visit, the geolocation of the visit, etc. And this information is not captured in the paper-based approach. So in view of this, these are a few of the variations that you get between the paper-based approach of implementing the campaign and the digital-based approach. Now, the data is received in the same way. However, you get more data using the digital tools than the paper tool. Now, in the collection, you receive the same data, and the data would usually then have to be processed. In the paper-based, it has to be collated to a different form that will now be presented at the different levels, at the department levels, and then it moves to the national level. But using the digital tool, you would see the same data shown in real time at the different locations on a dashboard. And the processing of this data will not have to do with like a physical, collation, etc. Also, how the data is understood is kind of different, because with the paper-based approach, typically the goal is just to say, okay, in terms of the coverage rates, how many have we reached and how many is yet to be reached. But in the digital, you can actually see the time that is used in each household, the drugs that are distributed, how many teams are active, etc. Now, how the data is understood and used became the first challenge that we had in 2019. Introducing the digital tool, the key staff at the Ministry of Health were utilizing the digital data that was shared on the dashboards as if it were a paper-based campaign that was being implemented. So this means that we had, relevant indicators that were built in the dashboards, but they would just be focused on the coverage rate of the campaign, and we're not looking at the effectiveness indicators that were within the dashboard to see how this could be utilized in implementing the campaign. Also, how the data is trusted as well was received differently. It was quite unfortunate that the paper-based data were seen to be, oh wow, this is the final data, this has been cleaned, this has been reviewed. However, the digital data, they still had some concerns that, well, this data has not been cleaned, this data is just received and reflected on the dashboard. Now, in view of all these variations, certain questions were now asked. How will these data be utilized to create a lot of impact? And first, we needed to understand that receiving the digital data, you get real-time information on how things are implemented on the field. And with this, you can be able to identify, to detect, and prevent, common challenges with implementing the campaigns. Also, you could, minimize data entry errors in the collection of the data. However, with the paper-based approach, this was difficult because in most cases, the utility of the data was, achieved at the end of the campaign. On my screen, I just wanted to show you an image of how the paper-based results looks like. And then on a face value, if you look at this report now, you can't really explain how the campaign has been implemented. You can't really pick out the results to use this result to, effectively understand if there are improvements, if the goals of the campaigns are met. However, in the next image that you can see, this is actually a coverage, the dashboard of a recent Unco campaign that was implemented in Benin. And here you could see that the staff of Ministry of Health can tell in real time that this blue dot, here you can see it represents individuals in the household who have received their preventive treatments. And also you can tell the households that are yet to be reached, those that have been missed across the different days of the campaign. And more importantly, is this point in red. Now, this household in red here signifies that this household refused this preventive treatment. Now, in the paper-based approach, you don't get this amount of information, and thus the use of that data is limited. But in the digital approach, you can actually tell with these relevant indicators to say, oh, wow, this household have refused this intervention. And then how do we follow up with this household to ensure that we can increase the uptake of the preventive medications that are being distributed? And then to our advantage as well, you have the opportunity to not just see these indicators, but also to follow through these indicators to see that if there are challenges, they are resolved within the course of the campaign. An example is then you can now click further on this dashboard to pick the geo coordinate of this household, and then the advocacy team can visit this household to clearly understand why they have refused this medication. Now, in conclusion, it's an advantage to see, the transition from the paper-based tools to the digital tools for health campaigns. But this requires a huge, mindset change by the Ministry of Health as to how the data is utilized to effectively improve the effectiveness of the campaign. And the data use happens when the perspective of the people is changing to now see the details within the data and utilize them in real time. Now we can have a digital campaign, but this campaign will not be effective if you don't have the effectiveness indicators included as part of the design of the digitization approach of the campaign. I think with this, I will stop with the conversation now and leave the floor open to other speakers. Thank you for listening.
Thank you very much, Elijah. Thank you very much. So before we move on to our second speaker, I see that there's quite a few people that have joined just recently, and I would like to go over a couple of announcements again. Please use the question and answer function or the chat to post your questions. We want to keep this session interactive, so please, I see that a couple of people have already posted questions. Please keep asking questions. So our second speaker is Christopher Lorenko. He is the Deputy Director for Malaria at Population Services International in Washington, D.C. Christopher will be presenting jointly with Bram Piot. Bram is the Senior Surveillance and Monitoring Advisor at Population Services International in Vientiane, Laos. They will be presenting on generating and integrating private sector case reporting and response into national systems in the Greater Mekong subregions. These are learnings from the Greater Mekong subregion elimination of malaria through surveillance program, also known as the GEMS program. Thank you, Christopher and Bram, for joining us today.
Well, greetings again to everyone, and thank you for having us here. As Sarah mentioned, we're covering an overview, a quick overview of the work done with the GEMS project, which stands for the Greater Mekong Subregion Elimination of Malaria Through Surveillance. It's a mouthful, but in summary, basically a combined package of case management and surveillance in this elimination setting. And we're going to talk about some lessons learned from that work, where we are today, and potentially what can be applied to some high burden settings. I'll give a quick overview of GEMS, and then I'm going to switch over to Bram, who will go over some of the more important details about the digital tools and processes that we had and challenges that we've had under GEMS. And then I will close with a review of some of the lessons learned. So the primary outcome for GEMS is the transition of the private sector network that we were supporting, switching over that direct oversight to the NMCPs. This is in Cambodia, Laos, PDR, Myanmar, and Vietnam, and integrating all of this work into a national malaria strategy and management structures. The key point from this slide is to remind everyone the amount of oversight that took place over many years in this project. Trying to think about the policies that had to be built, the relationships that had to be built with the partners and the NMCPs and the private sector providers. And this wheel that you see on the right is basically the support structure that we had in place. Everything from the network management, orientation and training, continual supervision, quality, commodities, ensuring that supply is constant, quality assurance work, and of course, case reporting. This is just to say that this doesn't happen overnight, and it's a long process, but needing this level of oversight for success. So this is just a slide to show that we are in the process now of transitioning a lot of the private sector provider support that we've been directly providing over to the government. And our work in Cambodia has finished in 2021, but we did transition some support there, knowing that the private sector network has changed in Cambodia. In Laos PDR, we have transitioned a total of 227 providers over to the government, and you can see these other figures as we move on. But an important message here is just to remember that some of these providers we see here as disassociated. Some of them have stopped operating, aren't receiving any febrile patients. So some of this is to also show that we can be very tactical in which private providers we are providing some oversight to. And if we have provided the right support and we see that fever cases, or again, malaria cases are decreasing, we can switch our oversight and supervision and support and keep it very pointed to where we see the greatest burden. This can be seen in some of the results that we have here, just showing the percentage of cases tested, captured in some of these private providers, and then the confirmed positive cases that are also captured. So a good example is in Vietnam, where you see a number of basically 1.2% of 1 million cases that were tested. And just with that 1% that we were supporting, we were capturing about 9% of the proportion of positive cases, just to show that we were hopefully putting our efforts in these providers that are seeing a good number of cases. Some of the highlights that we just wanted to touch on here. We had a few different models of private sector engagement in Laos. This included some SPC and full case management work, inclusion of private sector service providers into the reporting units. This is something that Bram can touch on later, but that was a big success, trying to support the integration of the private providers into the national reporting system. And seeing those as org units in DHIS2 is not an easy task, but very happy to see that merged into that country. We had some challenges in Myanmar, if you're familiar with the political instability recently. So we've definitely seen a decrease in the reporting rate, which is unfortunate, but something we're trying to continue to work through. In Vietnam, we're transitioning private sector network management to the national programs and the Global Fund subrecipients in last year, and that's continuing. Cambodia and Vietnam, we're seeing toolkits that were developed and disseminated last year as well. And this continues on through this year, where we're having the remaining GEMS providers transitioning to the national program in Laos and to the Global Fund subrecipients in Myanmar. We will then have some evaluation of these models in Laos to see what's best, and that'll inform the finalization of the private sector implementation SOPs there moving forward. And then we're going to move to a technical assistance role in Vietnam to help the government and the Global Fund and providers with this move as well. And as we mentioned on this last bullet, we'll go into more of the digital tools now, and I'll switch this over to Bram.
Okay, thank you very much, Chris. Hope you can all hear me fine. I would like indeed to highlight a little bit more what our journey in designing, deploying and using these digital solutions for improved private sector reporting in malaria elimination settings, such as in Southeast Asia, has looked like, because it really has been a journey. And we essentially moved from these custom-built mobile applications that PSI builds with a direct connection to DHIS2, always in mind to ensure full integration into existing systems. But where we started off with these custom-built tools, we called it the MCS, or Malaria Case Surveillance App, used in Cambodia and later adapted for use in Laos, and by Global Fund PR in Myanmar to use across a large network of village malaria volunteers. But that ended up being probably too cumbersome to maintain, to install, training, and the use of these custom tools requiring passwords and usernames was all pretty complex and heavy to maintain. We then switched, with support from the University of Oslo DHIS2 team, we incorporated a lot of the functionality that we had developed in our custom app into the core of DHIS2, into the Android capture app, as you see here on the screen in the middle, which was already much better because it's a generic tool that was more easier to evolve over time. However, there were still challenges around the ease of use and the requirements in terms of training and technical support and updating applications when new versions became available and so on. And more recently, we've now switched to what I see as more user-centered digital solutions rather than device-centered tools. The actual user-centered tools that are much easier to use. And we figured that we could leverage the power of existing social media channels, such as Facebook or WhatsApp or Viber, to essentially develop the reporting tool that the providers can use using the systems, the technology, the devices that they already have in their hands and that they are familiar with. And this has been proven to be really beneficial, as it allowed us to overcome many of these barriers around the usability and the user friendliness and other challenges that we've seen. Chris, maybe move on to the next slide, please. Currently, we're using this in the majority of our pharmacies and clinics within these networks. They're registered users and they use them for malaria case surveillance. So they will report individual cases along with the individual details, the village of residence, treatment given, test results, all the key data points that are required for surveillance through this chatbot. And this is connected to DHIS2 so that the data ends up in a structured way into PSI's MIS. And we're now transferring that to the HMIS, or where it still goes through PSI servers. We have a monthly data push so that the Ministry of Health, the National Malaria Program, also has access to these reports. In addition, we also have monthly stock reports, so we can also collect aggregate data that also connects to DHIS2 data sets. And while we initially focused on Facebook Messenger as the most widespread tool in Laos and Myanmar, and Zalo, which is a similar platform used only in Vietnam, we recently expanded to WhatsApp in Laos and Viber in Myanmar for a number of reasons, mostly because we realized that there's no one size fits all solution, and that we need to give people options, and that providers some may prefer WhatsApp over Facebook, or may not even want to have a Facebook account, right? Or are not familiar in using either of these tools. In Myanmar, it was slightly different because of after the military takeover, we had challenges with accessing Facebook, which was partly banned by the ruling government. We also built in automatic reminders for providers to ensure consistent and timely reporting, but also very importantly, case notifications to health authorities, so that the local health authorities, the district malaria officers would automatically receive an SMS or WhatsApp or an email so that they can immediately investigate and conduct a response as per the national guidelines for case investigation and response, which in elimination settings need to be very tight, and it's a matter of a few days. So you cannot wait until the end of the month before a case is reported and acted upon. And then finally, we've also seen how these tools allow for two-way communication, whereby we can use these social media platforms to push messages, behavior change messages, or other communications to the providers. I could expand a lot about all of this, but I think it's time to hand it back over to Chris for our final few slides. Thank you.
Bram, thank you so much. And yes, I already see some questions coming in, and hopefully we'll have a chance to expand on some of the good points that Bram covered. Now we just wanted to go over some of the realities that this work is taking place in a complex elimination environment in the greater Mekong subregion. But we have the hopes of transitioning a lot of this work into our high burden settings, and we wanted to talk about some of those challenges. Now, one of the points that I raised earlier is this point on engaging early. The success of this project was built on a foundation created by partners engaging very early with private sector providers through various mechanisms happening for many years. As private sector networks are often large and complex, they can be anything from a pharmacy to an informal sector, a faith-based network. Bottom line is that this engagement early is critical for building trust and relationship and seeing what makes sense in your setting and where we should target our efforts first. So trying to identify those key stakeholders in these contexts and seeking their buy-in is critical. Might be obvious, but it's just something we wanted to stress on the importance of how much time it took to develop those relationships and learn and build those relationships over time. And then thinking about maintaining this minimal number of data collection points for the NMCPs with actionable data without overburdening the providers. Trying to think about which providers we should target that really have that malaria burden, that has that relationship with NMCP, that we can actually inform the malaria response, and not thinking about having to do an overarching engagement with all providers in a system. And then building this comprehensive support program. We want to make sure that this program is built, but it takes finance and it takes support through other mechanisms like the Global Fund grants, and that's critical, working with those partners and stakeholders. And as surveillance is scaled up to the levels that we need for elimination, that financial support will be needed continuously for those plans to have a stable transition. And we're very grateful for our funding from the Gates Foundation that allowed for this another 4 years of sustainable transition planning. You know, this GEMS Plus phase is all for the transition and trying to do it as appropriately and smoothly as possible. And then what we saw encouragingly from some of our surveys is that 75% of those providers are willing to continue to report into the government surveillance systems after the project ends. And we're really happy to see that this highlights some non-financial motivating factors that encourage our work to move forward. And then the last 2 points is just trying to think about, as we mentioned before, prioritizing some starting points of care. We have to try to understand the preferences of those most at risk, which type of services they're seeking, and then using this to inform the types of providers to engage. We know that engaging providers maybe that are already accredited and recognized by the government may be a logical starting point, and just trying to think about where we can start and then build a logical approach. And then, as Bram mentioned, this involved a lot of leveraging of mobile technology. And this is something that we can go into in the question and answers, but obviously we want to start where maybe mobile coverage and ownership is high, and then we can think about using those social media apps, SMS, smartphone apps. But we know that that's not the case for all our settings, and trying to think about where it makes most sense to engage there. And then we said that this could bring on a dual burden of reporting on paper and electronic reporting as we see this transition. And that could be a barrier to consistent case reporting, and trying to understand what the burden is when we think about this transition is critical. And then obviously, as we mentioned and Bram mentioned earlier, the chatbot use we liked because it does help us minimize the effort required to install, train, update, and manage some standalone apps. And of course, we can get into the details in the discussion. But I'm going to stop there and again.
Thank you very much, Christopher and Bram. Excellent presentation. So far today, we've heard about 2 case studies, and now we will have a conversation about how ICT tools are being applied and data managed throughout the malaria project cycle across different levels of digital maturity. So I see that a number of you have asked quite a few questions. Please keep your questions coming. Again, for people that joined recently, please use the interpretation button at the bottom right of your Zoom screen if you'd like to listen to this discussion in French. So for this discussion, we are accompanied by the speakers, Elijah, Christopher, and Bram. And we are also accompanied by Moise, Hug, Renea Bomabo. Moise is the head of monitoring and evaluation unit at the National Malaria Control Program in Cameroon. Moise, thank you very much for joining us today. So far we have a couple of questions. So the first question.
Okay, bonjour.
The first question is for Elijah, and this question is from Mulugeta. It says, what technologies were used during the process for data collection, analysis, visuals, and others?
Okay, thank you for the question. I was actually just trying to answer that in the chat box. For the data collection, we usually utilize the Redrose platform, but for the data analysis and visualization, we have been using ArcGIS by Esri and Power BI. Over.
Thank you, Elijah. Thank you. The second question is for Chris and Bram. This is from Abraham. It says, what tool did you use to capture the cases in those countries? Thank you.
And I may take that question. We use the chatbot tools, right? So it's a combination, it's a tech stack that involves the social media platforms, combined with some intermediate chatbot engines. And we're now moving to a system called Rapid Pro, which is very closely linked to UNICEF and connects to DHIS2. So it's another global public good. And I think that also answers some of the concerns that I've seen in the chat around the need or the challenges around tools that are licensed, that are proprietary, or that require subscriptions. So we try to stay away from those. And then, of course, last but not least, DHIS2 is ultimately the data warehouse and the system that we use for analysis, where we have our dashboards that are built on the programs and data sets that that receive data through these chatbots. So it's a combination of different technologies. When, as much as possible, we always go for open source and free tools that ministries of health can also more easily take over.
Thank you very much, Bram. So the next question is for Elijah, and this question is from Marsha. For the various malaria campaigns that you're implementing, are you using an integrated application for digital data collection, or are you using a different application for each campaign? Thank you.
Okay, thank you, Mensa. I think this question is an important question. In CRS Benin, apparently we had developed a new software in collaboration with the Red Rose team called the Health Campaign Management Software. And this tool actually enables the implementation of end-to-end integrated campaigns with which you can use just a singular population database across different health campaigns. And this implies that you don't have to have a different application to implement a different campaign. So it implies that you can implement a malaria campaign, a river blindness campaign using the same application. And all you need to do is actually to add the relevant data parameters that has to be received across each campaign. And more significantly is the fact that you do not need to do a household enumeration across these different campaigns. It implies that you can use the population data set from the first campaign and incrementally update the household information across the visits to the different household in the different campaigns. I hope this has provided some information. However, we are happy to share more on how the platform is being used and how this works. Over.
Thank you very much. We have a question for Moise. Moise, what is your experience transitioning digital data collection to develop reports to more actionable timeline information? And how do you shorten the timeline from when data is generated to when it is acted on?
Thank you very much. In Cameroon, we implemented a digital transition for data collection in the rural, for the different campaigns. We started from a form, a data collection fund. We adopted an automated tool, BHC2, from the government in order to be able to get this data online. And so with this DHIS2 that's online, we have the advantage of having data in real time because the data is indeed within the server. So there is a delay of a maximum of 24 hours. So with this, before the supervisors leave to go out there in the field, we already have an idea of the situation. So it allows us to improve coverage, competencies. So with this approach, we shortened the delays or the timelines between data collection and analysis. The DHIS was used for data collection, but it also allowed generating dashboards that could be consulted and that could also improve the quality of the implementation. Another advantage is that some quality controls of data for validation are automatically integrated, and you can set the different parameters or settings. You can correct it and adjust the settings so that you can guarantee that the data used are quality data. So this is what I have to say regarding the this. And right now we are implementing currently automatic data collection regarding the campaign, the net distribution campaign. And I think that the results are quite encouraging. The delays have gone from 1 or 2 months to a maximum of 1 week after the campaign, that we could already have a maximum set of data so that we can make the general report over.
Thank you. Thank you very much, Moise. So the next question is for Chris or Bram. So I'll ask 2 questions. So the first question says from RGE, what proportion of private providers are participating? And the second question from Nora, how do you ensure data privacy, especially of PII, when using chatbots on commonly used messaging apps? Thank you.
Ram, I'll send this over to you, but I can just start by saying the number of providers varies in each of the countries, and briefly mentioned earlier was that it's strategically selected based on burden and ease of use and preference of the community. So it was a targeted set of providers. And what we saw was, even though it was a small set, a very small subset, sometimes only 1% of the providers in the network, that they were also responsible for a higher capture of testing and cases to show that, oh, we were targeting the providers that probably had the potentially a high burden or impact on the malaria context and transmission. But over to Bram with the details.
Yeah, and you're right, Chris. I think, and if that's okay, I'll maybe focus mostly on the question around data privacy and protection. And as that's a really important issue, I think it's a very important consideration. And it's not always easy to answer that question when using these large social media platforms such as Facebook. And even when data are expected to be encrypted and only used in aggregate form, it's not always transparent what their policies are or how that data is accessible even within Facebook. For us to mitigate this, any risks associated with leakages or breaches in data protection, we first of all, of course, will start by only collecting what's strictly necessary in terms of personal information, and that may include the patient's name and maybe their village of residence and nothing else. For example, no telephone numbers or other further details. If these are necessary, these may stay with the provider on paper, so that any case investigation done by local health authorities may be done in conjunction with the pharmacy or clinic where the case was initially detected. There's also mechanisms for them to refer to the nearest hospital if a patient needs to be followed up for further care and treatment. And of course, we always do this with the consent, informed consent of the consumer and of the beneficiaries, and the providers are trained on this. And we also make sure that data are only accessible to those that really require access. And the providers also still need to authenticate. It's not anybody who can connect to these chatbots. You need to be registered, and we essentially authenticate or match the profile of the provider against the DHIS2 org units that are in the system. And of course, also at the end users level, whether that's district, provinces, or national level, only a certain number of people will have access to the individual data. But again, the main thing is, I think, to limit the amount of personal identifiable information that we do collect. Thank you.
Thank you very much. Thank you, Bram and Chris. So we have a question for Elijah. How do you follow up with a household that has refused an intervention?
Okay, thank you so much. I think I already responded to that question in the chat box, but I'm happy to speak to it again. Apparently, we have a protocol in place that is utilized to resolve refusal cases and also absenteeism of the eligible population within the household. For the refusal cases, the protocol explains the steps that has to be taken by the advocacy team to first engage with the health administrators in these locations to try to understand if there are contextual, cultural issues that is resulting to the refusal. And upon this discussion with the health administrators at the visit level, then a visit is conducted to the household to speak directly with the household members that have refused the intervention, and in most cases, we'll spend time to re-explain to them the health benefits of this intervention and how useful this would be to prevent them from the disease case and to help them to stay, healthy through the period. In most cases, when the discussion is done, the households are then, convinced to receive the drugs. And if after this is done and they still refuse to take the drug, apparently the advocacy team now see how the household do not spread the false belief that they have to affect other people in the population from receiving the drugs. So right now, this is the approach that is utilized in Benin. Over.
Thank you, Elijah. That's wonderful. So the next question is for Moise. When referring to a tool or set of tools, is the preference to build in-house capacity or working with a vendor? What are the pros and cons for each? Thank you.
Thank you for the question. So it would be nice. We prefer to work with internal capacities so that we can make sure that we do capacity building at local level, because the skills that are developed elsewhere should also be profitable for the country, just as the local expertise. And we should not only rely on a single vendor, a single provider. Even in terms of advantages, it's less expensive because all the extra costs in terms of maintenance are reduced. It's better always if we have local capacities, and the solutions are also better adapted to the local context. So the needs are different for each situation, for a local situation, and it guarantees also the sustainability of the action and just a better control of the objectives of the program, so that we can also really adapt the actions to the solutions to the needs. In terms of disadvantages, we have an approach that's not always totally efficient, because if it was developed externally, well, then there are some elements that are not very well controlled by the local teams. So when we try to adapt external solutions, that can be a problem. And then there can also be a problem in terms of maintenance, because the local population needs some time in order to really control the maintenance. But between external and internal, the external providers guarantee technicalities and it's easier. They help in maintenance, but it's more expensive. But the internal takes into account the local context and situation. So I think that it would be good to do a capacity building, internal capacity building, in order to implement these campaigns. Thank you.
Thank you very much, Moise. So the next question is for Chris or Bram. Please, and this is from Percy, what are some of the data security issues you faced? What is the data ownership structure using these platforms? So there are two questions.
Yeah, no problem.
Yeah, that's another tricky one. It's important, of course. We haven't had any data security issues. We haven't faced any issues. We haven't come across any. So I can't speak to any first-hand experience. We are, of course, as I alluded to earlier, in quite a particular situation in Myanmar, where the government has blocked access to certain social media platforms, including Facebook, or has been discouraging users in various ways to access these platforms, and has tried to gain access to data. So that it links back to the earlier question around data privacy, of course. In terms of the data ownership model or structure, this is where we very closely work with the ministries of health, of course. And as I mentioned earlier, even though right now much of these data are coming through PSI's DHIS2 instances, ultimately they end up in the national HMIS, and they are shared either automatically or on a monthly basis under the form of reports with the ministries of health, who incorporate this into the national systems. And we're right now actively working to really hand over not just the management of these private sector networks that are so important in that last mile malaria elimination, where every case needs to be detected and investigated and responded to. But we're also handing over the technology so that they have full ownership. And it goes back to what Moise was also mentioning, how there are clear advantages of using open source global goods that ministries of health can use and manage themselves with some minimal capacity building. It's a process that takes time, but ultimately that also ensures that they have full ownership, not only over the data, but also over the system, and that they have the internal capacity to then expand, adapt, and maybe in the case of our chatbots, decide if they want to use this to collect additional data points, or if they would like to expand this to additional channels, whether that's the public sector or the community level, to provide, again, end users with options, so that they have the choice between different tools, and that could be all the way from paper to these advanced custom-built solutions, or apps such as the DHIS2 Android app and everything in between.
Yeah, and just a quick response as well, because I think Bram covered it nicely, and I think his example from Myanmar was critical, showing how things can change over time. And this is not a one-size-all approach, and this is an approach that we showed in that earlier slide that we'll share out, that things change over time as well, and preferences change over time with the MOH and with users. And I think we just try to strike that right balance, what is appreciated and what is preferred by the users, and also what will make sense for the national systems and finding that happy medium, and not always easy, but showing that this took years of engagement and trying to work closely with those health management information system units and partners to make this as seamless as possible. But again, years in the making for the work, and then years for the transition. So this is, Bram, correct me if I'm wrong, maybe an 8-year process we took between starting the actual implementation to now that transition phase in these 4 years. So yeah, it's a long process, but at the end now we see this integration and this ownership by the governments, and we're quite happy with that transition. Thank you.
Thank you very much, Bram and Christopher, for that comprehensive answer. So we are running out of time now, and we are coming to the end of our session. There are so many interesting questions in the chat. If you have any pressing questions which we did not answer today, please feel free to reach the panelists directly, or the organizer as well, for this conference, to make sure you get your questions answered. So I would just like to thank you very much for joining this session. And just as a quick reminder, please fill out the session feedback poll. The section feedback poll for this session as well. So we come to the end of the time, as I mentioned, and we're gonna keep going today with the rest of the sessions for this conference. Thank you very much for joining us. And we really appreciate you being here and asking so many interesting questions. And thank you very much to the speakers for very interesting presentations, and for Moise for joining us for that discussion session. Thank you so much.